This conference will now be recorded.
Okay, so we'll be continuing with the gallbladder, which we had started two classes back. And last time we had talked about the gallbladder stone, the types of stones, and some of their symptoms. Now, this time we'll be talking about the inflammation of the gallbladder, and starting with the most common type, and that's the acute cholecystitis. So we've got two types of acute cholecystitis. The first one is a calculous cholecystitis, which is the more common type, with the typical presentation that we'll be referring to that you know of mostly. May have a rapid progression or a slightly less rapid. Usual type referred to in all discussions of acute cholecystitis. So whenever we talk about acute cholecystitis, when you say acute cholecystitis, you basically mean a calculus type of acute cholecystitis. For the simple reason that the acalculous cholecystitis is a less common entity, more commonly seen in severely ill patients when ICU, like a patient admitted in ICU or a patient who's in sepsis, and usually there is no prior history of biliary colic. And these patients may present only with fever and sepsis. History and physical examination usually does not point towards the diagnosis of an acute cholecystitis. And if you have identical conditions for a calculus and a acalculous cholecystitis, the patient with a calculus cholecystitis would be having a very rapid course as far as compared to acalculus, which is having a indolent progression. Emphysematous type of cholecystitis variety that's more common in acalculous cholecystitis. Now let's look what happens when the patient has calculus cholecystitis. So we look at the physiological events and outcomes. So you've got this gallbladder stone, and this gallbladder stone may be asymptomatic, which usually is the case. It may be presenting with a biliary colic, which we referred to last time, the Rome classification that we talked about. How do we classify biliary pain? Or the patient may be having an acute cholecystitis, or the patient with the gallbladder stone may be having chronic cholecystitis. Now, here let's focus on the acute cholecystitis. Now, if you have acute cholecystitis, let's look at the right part of this chart. So you can have a spontaneous resolution after an attack, which usually occurs in 70 to 90% of cases. In about 25% of cases or less, you have a gallbladder lump formation. And this gallbladder lump formation is usually either a phlegmon, and we know what a phlegmon is. It is a combination of a gallbladder, inflamed gallbladder, along with the adherent omentum, the greater omentum, the transverse colon, the small bowel, and the parietal peritoneum. That basically means the adjacent structures lying in close vicinity of the gallbladder. And number two, the second reason why you can have a gallbladder lump in acute cholecystitis could be empyema of the gallbladder, which is infected bile, may even be a frank pus. The third reason why you can have a gallbladder lump in acute cholecystitis could be a mucocele of the gallbladder. And that mucocele gallbladder, as opposed to empyema, is a collection of non-infected, clear, mainly mucoid collection. So when you have or you aspirate a mucocele, you find absolutely clear, transparent fluid or slightly milky fluid, and there's no hint of pus in the gallbladder. Another reason why you can have a gallbladder lump could be a pericolic abscess. That means there has been a localized perforation and abscess collected around the gallbladder, giving rise to a lump formation. So the first was spontaneous resolution. The second is the appearance of gallbladder lump, and four reasons to it. The next presentation I could call a status could be that is so fast and so rapid, and the ischemia is so vast that the patient undergoes gangrene of the gallbladder, or with this gangrene gallbladder or a severe acute cholecystitis, there has been a perforation in the gallbladder. So that will lead to a localized either a pericolic abscess, which just now referred to, or it could be a saphrenic abscess, which could be in the area of the Morrison's pouch, or it could be generalized peripheral. And of course, along with that, you have an associated acute cholangiohepatitis. So these are basically the outcomes of an acute cholecystitis. Now, the left side of the chart will be referring to in the later part of this lecture, which are the various types or special types of acute cholecystitis, and we'll be talking about that then. So, how does the acute cholecystitis, remember again calculus because that's the most common type, how does it usually present? The pain, the local symptom is important in the form of pain, which is a persistent biliary pain of more than 8 hours duration. Remember, this time period is important. Why any pain less than 8 hours duration is usually a pain of biliary colic. If it proceeds more than 8 to 9 hours, then you tend to call it an acute cholecystitis pain, right? So usually the right hypochondrium often starting the epigastrium, but it could be as compared to the biliary colic, which we remember last time we said that it could be found in 6 areas. Here, the pain of acute cholecystitis is more or less always localized to the right hypochondrium, epigastrium, and you can have a referred pain to the right shoulder and the back. Initially, the pain is colicky to start with, and later becomes persistent once the parietal peritoneum starts getting inflamed, or there could be a diffuse epigastric pain to start with. Reference to the right shoulder and back and retrosternal are features which would be there once the parietal peritoneum starts getting inflamed and may become generalized subsequent perforation. That means now you have a generalized pain in the whole of the abdomen. So instead of having a primarily epigastric right hypochondric pain, now you have a pain which is generalized throughout the abdomen. And that usually is the scenario when you have a perforation in an acute cholecystitis. The systemic signs of inflammation may or may not be present, but usually more often than not, they are there in the form of fever, jitters, and nausea and vomiting. The signs are important, and the general signs are related to the tachycardia, the fever, the pain during inspiration, a very typical symptom, especially, a very typical sign, especially. So, this should be mentioned as tenderness during inspiration, not pain during inspiration. That would be a symptom. Tenderness during inspiration would be a sign. So that would be there when the parietal peritoneum is inflamed or the gallbladder is so huge, inflamed gallbladder is so huge, that it tends to come in contact with the parietal peritoneum momentarily during the zenith of the inspiration. Jaundice is there only in 15% of patients. And what is characteristic about this jaundice? And this fact is important. Why? Because this forms an important therapeutic implication. Meaning thereby, you have a patient with acute cholecystitis and he also has jaundice. Now, your decision is very important whether you would like to operate on this patient right now or you wait for the jaundice to abate. Why? Because there could be other reasons for jaundice. So, in a patient who's got jaundice, the acute cholecystitis, if the jaundice is usually less than 4 milligram percent, usually the cause would be a Meniere's syndrome or an associated cholangiohepatitis. But if there is a CVD stone, then the chances of jaundice remaining at 4 milligram percent would be less. It keeps on going and the bilirubin level is higher. So the level of jaundice is important when you're dealing with a patient with acute cholecystitis. The local signs, as I said earlier, tenderness in the right hypochondrium. Number two, the Murphy's sign. And Murphy's sign, look at the sensitivity. We have been talking a lot about the Murphy's sign. It should be there. It should be there in every patient know. The sensitivity and specificity varies right from 48 to 97%. That's a huge range. That's a huge range, which basically tells you only one thing. That's neither it is very sensitive nor it is very specific. But what is the Murphy sign? A sudden catch in the breath at the zenith of inspiration, with examining hand applying slight pressure over the right hypochondrium, which is also used for eliciting rebound tenderness. Now, the Murphy sign can also be elicited with an ultrasound, and that's known as the ultrasonic Murphy sign. The third is a Boas sign. And what is a Boas sign? A Boas sign basically is a sensitivity of only 7%. Remember that. So this was mentioned earlier. That's why I picked this up. But it is an absolutely non-specific sign. But what is it? It is a hypersensitivity in the right infrascapular between the ninth and the 11th rib, again because of inflammation of the posterior parietal peritoneum, right? But look at the sensitivity, 7%, so you can tend to forget it if you want to, but if you want to remember it, you should remember that's a highly insensitive sign for acute cholecystitis. But the lump in right hypochondrium, we just not talked about that, and the reasons why you have a lump, because the reasons we had the lump and found in almost 30-40% of cases, and this we said empyema. Why does empyema occur? We said the empyema would be the reason, but usually occurs when there's an impacted stone at the neck of the gallbladder, and there may be sudden resolution to this lump also. The stone gets disimpacted, everything drains to the CVD, the lump disappears, right? You can have a phlegmon 25%, and if you have a phlegmon, remember it will start 48 hours after the onset, forms by the end of seventh day. That means end of first week, you have a definite lump. I wouldn't say a very clear demarcated, it's a definite lump. You can feel there's a lump there, and resolution usually takes about 3 to 4 weeks. Biliary peritonitis, you have a generalized tenderness and guarding of the whole of the abdomen. A stone can perforate the gallbladder into the duodenum or stomach, giving rise to later on generation of paralytic ileus. which is known as gallstone ileus. You can have a mucocele of the gallbladder, again block at the cystic duct with non-infected bile, and because absorption of bile salts and pigments occurs, that's why only mucus remains, and that's why you get a clear, transparent fluid. A hard lump mimicking carcinoma gallbladder is a definite entity, and it is very characteristic of either carcinoma of the gallbladder or a differential diagnosis of acute cholecystitis known as xanthogranulomatous cholecystitis. So you can have a hard lump in the post-acute cholecystitis either because of phlegmon. If it is even harder, then it's probably xanthogranulomatous cholecystitis. And a late lump appearing in the right hypochondrium could be an abscess. Peritonitis, we already talked about that, right? Now, special groups and what are the clinical features? Now, two special groups need mention. One, the elderly patient, and number two, the children. In elderly patient, the old patient, and especially if the patient has diabetes, then the symptoms are pretty vague and without many key historical or physical findings. So, in these patients, the pain and fever may be absent, even in diabetic patients, even otherwise, diabetic patient tends to have less of pain because of paralysis of the autonomic nervous system. Localized tenderness may be the only presenting sign in these patients. So the patient does not have pain or fever, it's only vague symptomatology, localized tenderness. And it may progress to complicated cholecystitis rapidly without warning, without giving ample time to manage that patient. In children, the pediatric population, there's a group of patients who are at high risk. And who are these patients? Especially in those where there's increased chance of hemolytic anemia, like example, sickle cell disease. Seriously ill patients, those on prolonged total parenteral nutrition, those with hemolytic conditions, and those with congenital and biliary anomaly. So these are the two groups of patients that you need to be careful about when you're trying to make a diagnosis of acute cholecystitis. So when you're looking at a diagnosis of acute cholecystitis, what else comes to your mind? Number one, you should be always looking for or considering a subhepatic appendicitis. You should be looking at a localized duodenal perforation. You should be looking at acute pancreatitis. You should be looking at liver abscess and rarer conditions like pleuritis or pneumonia of the right lobe, which can manifest with lower chest symptomatology, which is akin to right hypochondrium pain also. The patient could be having myocardial infarction, or the patient could be having acute pyelonephritis. So these are the important differentials. That in no way is this list complete. Please remember that this is not a complete list, but this gives you the important differential for acute cholecystitis. So that brings us to the investigation. So you are in a dilemma whether the patient really has acute cholecystitis or not. Then you go ahead and do the investigation. So you have a whole list of investigations. Among them, the important ones: the patient will be having a polymorphonuclear leukocytosis. The liver function test may or may not be deranged. Remember, that is very important. If the patient has associated cholangiohepatitis or the patient has associated cholangitis, the liver function test may be deranged. Jaundice is always less than 4 milligram percent in uncomplicated acute cholecystitis, usually obstructive or biphasic. And the reason is simple: acute cholangitis, acute cholangiohepatitis. The ALP is raised in 25% of patients with acute cholecystitis. Now, whenever we talk about the alkaline phosphatase, we say it's a very important marker for obstruction of the common bile duct. Agreed. But in a patient with acute cholecystitis, even without obstruction, there could be a rise in the ALP to almost 25% of the patient. The AST, ALT, which are primarily liver enzymes, are normal, but they could be in acute cholangiohepatitis. The serum lipase amylase should be normal. If it is raised, then you will start thinking in terms of an acute pancreatitis or calculus pancreatitis. Ultrasound is the mainstay of diagnosis, and it is pretty sensitive and pretty specific. 90 to 95% sensitivity, 78 to 80% specificity. If you look at the diagnostic capability of ultrasound as far as gallstone is concerned, without any cholecystitis, 95% sensitivity and specificity for stones more than 2 millimeter diameter. So I mentioned the GSD here just to give you a comparative figure as to the diagnostic sensitivity specificity figures of GSD, that is the bladder stone disease, as compared to acute cholecystitis. Stone impacted stone can be found on ultrasound, impacted at the cystic duct or at the neck of the gallbladder, a pretty common finding on ultrasound. The CBD should be less than 6 millimeter. Remember that. And acute cholecystitis, if you have started having a CBD more than 6 millimeter, that basically tells you that if it is just marginally beyond 6, it could be because of inflammation or associated cholangitis. But let's say it is more, 7 millimeter, 8 millimeter, then please start thinking of a obstruction in the CBD, most commonly a stone in the CBD. Gallbladder wall thickness is the one of the most important findings, and if it is more than 4 millimeters, that basically tells you that there is edema of the gallbladder or thickening of the gallbladder. In either case, if it is acute cholecystitis, it will be edema. If it is chronic cholecystitis, it could be fibrotic thickening. So, more than 4 millimeters, a pathological wall of the gallbladder. Then you can find gas in the wall in emphysematous cholecystitis. Pericholecystic collection is another feature on ultrasound. Hydros basically means an inflamed gallbladder filled with fluid. Sonographic Murphy sign, I refer to that. That could be elicited, that can be elicited. And remember, an ultrasound is not the preferred method for diagnosing any pathology in the retroduodenal CBD. You all know that, but it needs repetition time and again. That if we're talking about the retroduodenal part of the CBD, because of the overlying gas in the duodenum, which is overlying that part of the CBD, it becomes a very poor investigation for diagnosing any pathology in the retroduodenal part. Coagulation profile may or may not be abnormal, but then that has to be done in every patient with acute cholecystitis. What about the other investigation? Cholecystosynthesis scan with radioisotopic analysis, the HIDA scan, sensitivity specificities are in the range of 90 100% and 85 95%. Pretty good specificity and specificity. Sensitivity and specificity, remember that. And a very good investigation, but not routinely done because it involves radioisotopes and ultrasound serves equally well. So that should be reserved for select few patients where the diagnosis is not pretty clear. CT scan preferable in a patient acute cholecystitis when you're suspecting a CVD pathology. So the retrodural part you're not able to see and you're suspecting something, do a CT scan. Otherwise, a CT scan is not mandatory in acute cholecystitis. Please keep that in mind. There are specific indications when you like to do a CT scan. Number one, you want to target the retrodural part of the CVD where you're suspecting some pathology, or you got a CVD diameter more than 6 millimeter, a history of recurrent cholangitis, a raised ALP, and suspected infiltration into segment 4 and 5, where you're suspecting a carcinoma, which is behaving as an acute cholecystitis. So these are the only scenarios where a CT scan becomes mandatory in the diagnosis of acute cholecystitis. Then you come to ERCP, which is both diagnostic and therapeutic, a very, very important method of differentiating CBD stone as in contrast to acute cholecystitis without CBD stone. And then MRCP, which delineates the whole of the anatomy of the extrahepatic and intrahepatic biliary system, ductal system, and it confirms the luminal findings. Now, coming to grading, which is now important thing, and you have to grade acute cholecystitis. Why do you want to grade the acute cholecystitis? Because that gives you indication of severity. And why do you want to know the severity? Because that is a pointer towards the management of acute cholecystitis. So for that, the Tokyo guidelines of 2018 are followed everywhere universally, and the guideline, let's start with grade 3, grade 2, and grade 1. Why reverse? Because it becomes apparent as we go forward. So grade 3 is an acute cholecystitis associated with organ dysfunction. This is a wide generalization. We'll be more specific in the next slide. So when you talk about grade 3, we're talking about acute cholecystitis with organ dysfunction. That basically means the other organs are involved. So, for example, you can have a pancreas, you can have kidney involvement, and so on and so forth. We'll talk about that next time. Grade 2 is a severity which is known as moderate acute cholecystitis. And how do you generalize it? It is a condition or it is a stage of acute cholecystitis where it is difficult to perform cholecystectomy due to local inflammation. That's a generalized view of moderate or grade 2 cholecystitis, acute cholecystitis. Mild one, grade 1 is basically the acute cholecystitis which does not meet the criteria of 3. That's one way of looking at it. Another way, you can define grade 1 as a cholecystitis in a healthy patient with no organ dysfunction, mild inflammation gallbladder, making cholecystectomy a safe and low risk operative procedure. But if you want to be more specific about these guidelines, then the mild is basically what we just now talked about, but grade 2 becomes more specific, and that is you have presence of one or more of the following parameters. A white cell count more than 18,000. Remember, see this. 18,000. Normal, we always consider the upper level 11,000 or 12,000 at the most. Here it's 18,000. Palpable tender mass, duration more than 72 hours, and marked local inflammation in the form of what is mentioned out here. So if you have one or more of the following, that is grade 2. But if you have the presence of one or more of the following, then you've gone into grade 3, which basically means cardiovascular dysfunction, hypertension requiring treatment with dopamine. I'm not going to read the whole thing out. Neurological dysfunction, respiratory dysfunction, renal dysfunction, hepatic dysfunction, and hematological dysfunction. So you have all these multiple organ involvement, either one or more than one, then you start calling it a grade 3 severity of acute cholestasis, right? Now, as I said earlier, these Tokyo guidelines are number one prognostic and number two they're therapeutic also. So if you have great prognostic, it tells you if you got multiple organ failure or involvement, the chances of morbidity increase, the morbidity increases and chance of mortality also increase. So if you have grade 1 mild, then antibiotic general supportive care would more or less suffice. You finish the course of antibiotics and then you treat one for the etiology. If it's still needed, go ahead and do it. If you find that the antibiotics are not responding fully, then you need to go in for a biliary drainage, right? You have to drain the infected one. Grade 2 moderate, you have an antibiotics and general supportive care same, but an early drainage is always required in grade 2. Why? Because here the symptomatology is much more severe than grade 1. So the the severity is so more than the grade 1 that here you require an early drainage. In grade 3, urgent biliary drainage. You don't wait. Here it is early. Here it is urgent. Organ support urgent. And antibiotics, you switch on to the higher and higher groups of antibiotics. In all this, the end point is if treatment for etiology is still needed, you go ahead and do it. And what is the treatment etiology? The stone. Obviously, the stone. If it's A calculus, you can afford not to remove the gallbladder at that point of time. You can wait. In acute cholecystitis, so removal or treating the primary etiology becomes important, and that can be with the help of endoscopic treatment, percutaneous treatment, or surgery. So that is how the Tokyo guideline helps you in managing a patient, right? Now coming to the conservative management, we just now refer to here as general conservative management. So what is the conservative management? That's very important. Why? Because most of the time when a patient comes to acute cholecystitis, more often than not you advise him surgery, he'll say no, treat me with medicine. So you have to go ahead and do a conservative management. That's point number one. Number two, a patient who comes to you after 7 days of onset, when he's already got a gallbladder lump, that is the patient for conservative management. So number one, a patient not inclined for surgery. Number two, a patient with a gallbladder phlegmon or more than 7 days duration. These are basically patients who are primarily for a conservative management. So you have the oral, if possible, keep the patient on oral therapy. That means continue oral intake in the form of liquids or semi-solids, antibiotic coverage along with pantoprazole or any other proton pump inhibitors. What about the antibiotic coverage? Prefer the cephalosporins, especially the the second generation cephalosporins. Prefer the floxacins. So you got the ciprofloxacin and a combination of amoxiclav. So these are three groups of antibiotics which are preferred in acute cholecystitis. So you got the second generation or higher cephalosporins. You got the floxacins and you got the combination of amoxiclavularic acid. Anaerobic coverage is always metronidazole, and that has to be included in the coverage of antibiotics. Antispasmodics and antipyretics as required. So continue this treatment for 7 to 10 days or more until you find complete resolution of symptoms, right? Now, if the patient has got recurrent vomitings, the patient is severely tachycardic, the patient has got severe pain, the respiration shows tachypnea, severe abdominal pain, tenderness, not responding to conservative therapy. In all these cases, and if there is distension of abdomen, in all these cases, stop oral. Put this patient on IV supplementation, use parenteral drugs, monitor the patient for physical signs, especially the general symptomatology and the local abdominal signs. If you find that the patient is responding to IV supplementation, continue it for 7 to 10 days more, or if required, even more. If there is no response, you just wait for 48 hours. And 48 hours down the line, if you find your conservative therapy is not showing the desired result, you go ahead and go in for any kind of surgical intervention. We just talk about that in the next slide, right? So, if there's aggravation of signs and symptoms, non-response to conservative therapy, you have to go in for early surgical intervention. It is similar to remember the Oshner regime for appendicular lump. Remember appendicular lump? You treat conservatively, 48 hours down the line, no response, go ahead and intervene, do an appendectomy or drainage, whatever is required. So similarly, out here, conservative therapy should show results in 48 hours. If it doesn't show results in 48 hours, that becomes a case for surgical intervention. So what is the surgical intervention all about? So if it is just plain and simple biliary colic, I've just mentioned it here. So just forget this. We already talked about the gallstone. So the patient has come with the gallstone with biliary colic, laparoscopic or open cholecystectomy. So the treatment is cholecystectomy. But let's talk about the acute cholecystitis here. So the patient has come to you within 7 days of attack. The preferred should be a cholecystectomy. Excuse me. Again, either laparoscopic or open method. But a patient who's come to you after 7 days without phlegmon is again a patient for laparoscopic cholecystectomy and standard cholecystectomy, either of the two. See, what is important here is without the phlegmon. That means this is a patient who has got either empyema or a mucocele, and these can easily be tackled even in the second week. Remember that. But if the patient has got a gallbladder lump along with a, uh uh, adherent bowel with either transverse colon or small bowel, then that is a patient who should be treated conservatively, right? So the immediate surgery or the surgery at the time of admission is advisable. Number one, when the patient has got acute cholecystitis less than 7 days duration, in any patient, whether it is less than 7 or more than 7, if the patient has only empyema or mucocele without phlegmon. So that should be pretty clear in your mind. But if the patient has got phlegmon, please do not go ahead and do a cholecystectomy in that patient. Just carry out conservative therapy and follow this up with interval cholecystectomy in 4 to 6 weeks. But the problem comes failure of conservative. See, last slide we said if the conservative therapy fails, that means 48 down the line, the patient has got a failure of conservative. Go ahead and do a laparoscopic or standard cholecystectomy. That's not the only options available with you. Your other options available at this point of time, you should note that down, and that is number two, cholecystostomy. That basically means that either cholecystotomy or cholecystostomy. Remember, two different terms. I've repeatedly been telling you otomies and ostomies. Otomy basically means open and close it. Ostomy means open and create an opening either temporarily or permanently to the exterior. So in a patient where you find a gallbladder phlegmon and you go in the abdomen and you find you can't dissect anything, please do not try to dissect the gallbladder. You're going to injure, you're going to harm the patient much more than you're going to benefit the patient. So the option is, so then the question is, this patient will not respond to conservative therapy. So what should I do? Drain the pus. That means do a cholecystotomy. Drain the pus, make an opening in the gallbladder, drain the pus, remove the stones, close the gallbladder, come out. That is otomy. But a preferable method more than anatomy is because remember that patient has got a block at the cystic duct, either temporary or permanent. So a better option would be a cholecystostomy. So you can do a cholecystostomy. That means you open the gallbladder and you attach it to the parietal peritoneum and connect to the exterior. So now you got a tube from the exterior percutaneous tube going directly into the gallbladder, and you have already drained the stone and the pus. So that tube is going to keep on draining whatever gets accumulated inside the gallbladder. So failure of conservative therapy, if possible, go ahead and do a cholecystectomy. Again, option is your a laparoscopic or standard. Number two, cholecystotomy. Number three, cholecystostomy. Number four, another important option available is a partial cholecystectomy. And partial cholecystectomy basically means whatever you have dissected out, you do a excision. Leave the rest of it behind and close the gallbladder. And how do you do that? I'll just come to the next line. So, in a patient where you have a difficult dissection of the Gallus triangle, either as a primary intervention or you are operating on a patient with failed conservative therapy, in either case, in fact, in any case, when you got a problem in dissection of the callous triangle, then the options available is that per-operatively, either you do identification with the ICG, near infrared uh, radiography, which we refer to when we're talking about the gallbladder investigations. Or number two, if you don't have that facility with you, that's a costly facility, then you should do a partial cholecystectomy. And what happens to the stump that you leave behind? You should always do a mucosal cauterization. So if you burn the mucosa from inside the stump which has been left behind, that becomes a functionless gallbladder, and then you close that stump. So that is perhaps one of the best options available as of now in those patients where there is a difficult dissection of the callus triangle. The third option, we already said, a cholecystostomy with a later on interval lap or open cholecystectomy, right? If it is a perforation, cholecystitis perforation, a cholecystectomy. When should you do a prophylactic cholecystectomy? We'll talk about that later. Plus minus CBD exploration. When should you do a CBD exploration with lap or open cholecystectomy? Again, that question usually does not arise in an acute status. So we'll usually or we'll skip this point at this point of time. So when you talk about acute cholecystitis, a CBD exploration usually should never be done in acute cholecystitis. It should be, if at all you want to intervene in the gallbladder, it should be a endoscopic intervention. Now coming to the varieties of acute cholecystitis, and what are the varieties of acute cholecystitis? The first one is A calculus, which we refer to when we talk about the types of acute cholecystitis. So 5%, 10% of all acute cholecystitis are A calculus. 1 to 2% of all cholecystectomies are for A calculus. It is basically a non-calculus obstruction. So obstruction is still here, but here it's not a stone. What is obstructing cystic duct? It is edema at the cystic duct level or the neck of the gallbladder, which is causing the obstruction. And secondary to that is a bloodborne infection, right? Acalculous cholecystitis usually has a higher incidence of gangrene, perforation compared to calculous cholecystitis. It has a higher incidence of emphysematous cholecystitis, which we referred to in the first or second slide. It has got more serious morbidity, higher mortality rates than calculus cholecystitis in those patients where you tend to miss it. Because remember, this has got an indolent course. But if you miss the diagnosis of acalculous cholecystitis, then it's got high morbidity and higher mortality rates. And the mortality figures are 10 to 15% acalculous as compared to 1% of calculus cholecystitis, for the simple reason that you have done ultrasound, you don't find a stone, and you say this patient doesn't have acute cholecystitis, he must be having something else. While all the time the patient was having acalculous cholecystitis. So because you tend to miss the diagnosis, the morbidity and mortality figures creep up as compared to calculus cholecystitis. The pathophysiology, we already told you that it is the mucosal edema caused the block leading to bile stasis and increased lithogenicity of the bile, and commonly observed where in very ill patients. So it's usually in patients who are in the ICU, or the patient with severe sepsis, or patient with severe burn injury or severe trauma. Because in all these conditions, because the oral intake has decreased, so the bile tends to become increasingly viscous. Dehydration is an important feature in all these patients. Now, prolonged absence of oral feeding has another added reason why you have a increased lithogenicity of the bile, and that is the CCK, cholecystokinin, induces gallbladder contraction, so that decreases. The gallbladder contraction is no longer occurring. Why? Because what stimulates CCK? Oral feed. But this patient is so severely ill, he's not taking anything orally. So CCK is not coming into play. So the gallbladder remains flaccid. So the bile remains there for a longer period of time. So the absorption occurs more, and so it becomes more viscid. Gallbladder ischemia that occurs because of low flow stage is a feature in acalculus. Why? Because a patient of sepsis, a patient of severe burn injury, severe trauma tend to be hypovolemic, tend to be hypotensive. So that also reflects on gallbladder ischemia. So that ischemia of the gallbladder wall would again lead to an increased chance of acalculous cholecystitis. Now, the patients who are susceptible, apart from these sepsis and those with severe burn injuries, are patients on TPN, cardiovascular disease, diabetes, gallbladder dysmotility, pregnancy, and a AIDS cholangiopathy. So these are the patients who have got an increase in acalculous cholecystitis. The diagnosis is not very easy, and here ultrasound or CT scan gives you a pointer, and the gallbladder wall edema is a very important indicator. Preoperative diagnosis, the thick gallbladder wall, and the second thing is a less than 50% reduction in size after fatty meal. This figure is important. So you do give this patient a normal meal, and if the patient, of course, is taking orally, and less than 50% reduction would give you a diagnosis of acalculous cholecystitis. But that's usually not the case because the patient is so severely ill. So a thick gallbladder wall more than 4 millimeters high would be a pointer even without the presence of a stone. And obviously, acalculous cholecystitis would be without a stone. So chronic acalculous cholecystitis, there this comes into play. 50% reduction in size should be there, and these are patients who present with recurrent biliary pain. All investigations are normal, no stone is found, and in some of these patients, chronic acute cholecystitis could be a patient of biliary dyskinesia, and that's why diagnosing a chronic acute cholecystitis is a very, very difficult proposition. Don't go ahead and diagnose acute cholecystitis chronic form very easily, because you would be creating a problem for yourself. Then the Watkins biliary cardiac syndrome. This is basically a syndrome which mimics a cardiac disease. That's why it needs mention. This is a cholecystic pericardial manifestation. So these patients have got syncopal cardiac attacks seen in 1.78% of acute cholecystitis, disappears after surgery on biliary tract. So therefore, there is a relation between the cardiac and the biliary system. And that is the reason why this forms an indication for polycystic. Acute cholecystitis and cardiovascular disorders share a complex and reciprocal relationship, right? And cardiovascular disease is a recognized risk factor even for acute cholecystitis, and acute cholecystitis is a risk factor for cardiac disease. So they work both ways. Gallstones also increase the risk of cardiovascular disorders, including stroke, coronary disease, cardiac failure. And then primary biliary cholangitis patients, the cardiac involvement in about 4% of cases. So what we are trying to say is that there's a close relationship between the biliary system and the cardiac system, whether it is just plain and simple gallbladder stone disease, or it is acute cholecystitis, or it is chronic cholecystitis. In any case, in any scenario, there is a relationship between the cardiac and the the gallbladder system or the biliary system. Emphysematous cholecystitis, what is it? It is basically a form of cholecystitis more commonly seen in males, older age group with diabetes mellitus, and said earlier in acalculous form. It is a highly virulent and unusual variant of acute cholecystitis, right? What is the reason? The reason is a gas producing infection, a gas producing bacteria, most commonly Clostridium, which accumulates in the lumen. The gas increases the pressure inside the lumen. The mucosa goes under ischemia. That ischemia leads to mucosal ulceration, and that ulceration, now the gas escapes into the wall of the gallbladder, right? So you have a gas accumulating in the lumen, in the wall, or it can go beyond the wall in the pericholecystic area. Several synonyms of emphysematous cholecystitis have been used from time to time, like acute gaseous cholecystitis, pneumocholecystitis, gas gangrene of the gallbladder, gas phlegmon of the gallbladder, and aerocholecystitis, and so on and so forth. But the most commonly and accepted terminology is emphysematous cholecystitis. So, unlike acute cholecystitis, where there's systemic obstruction, now, physomatous cholecystitis, it is primarily because of ischemia of the gallbladder with superimposed bacterial infection. We talked about acalculous cholecystitis. Preoperative diagnosis, you find pericholecystic gas collection. And remember, when you talk about the ultrasound diagnosis, we talked about the champagne bottle sign, where you find gas in the wall of the gallbladder. So these two signs will help you in making a diagnosis. The other variety, the next variety, is xanthogranulomatous cholecystitis, which we referred to in one of the slides, and we said this becomes a very important differential diagnosis from carcinoma of the gallbladder, and that is where it is important. So the incidence ranges from 5 to 32%, which is not a very low percentage. 9% of all cholecystitis in India are xanthogranulomatous, which is not a low figure. 9% is a high figure. 1.5% of routine cholecystectomy specimens are xanthogranulomatous cholecystitis. And the mean age of presentation 44 to 63 years. Now, some studies have shown a male preponderance, but others say there's no gender predilection. Distinct clinical entity and significant morbidity. Why? Because the inflammatory process is so huge and so massive that it extends into the gallbladder wall and adjacent structures. The differential diagnosis is very important, and for that you have to know the characteristics. So the characterized by number one, focal or diffuse destructive. So the inflammatory process is destructive, pretty destructive. That's why it becomes massive. Accumulation of lipid-laden macrophages, yellow brown nodules on naked eye examination, and hypertenuated nodules in the gallbladder wall are all pointers towards the diagnosis of XGC. Pathogenesis is obscure. Probably, as I said earlier, inflammation with gas producing organism, along with what else is happening? Extravasation of bile into the gallbladder wall from rupture of these sinuses or mucosal ulceration. Why does that occur? I told you, infection leading to increased pressure build up inside the gallbladder lumen, leading to ischemia of the mucosa. So these events they incite an inflammatory reaction in the interstitial tissue, and you have an accumulation of fibroblasts, macrophages, all laden with biliary lipids, and these are known as xanthoma cells. And because of identification of these xanthoma cells, it is known as xanthogranulomatous cholecystitis. Remember that. So this is an important histological feature which gives the typical name to this form of acute cholecystitis. Gallstones are present in most cases, but may have whether they have a pathogenic role or not, we don't. Macroscopic appearance. Usually, the gallbladder may be small, but dense adhesions are usually encountered during operation. Generally, mimics a gallbladder carcinoma. So it not only imitates the gallbladder carcinoma, it can also be in association with primary adenocarcinoma. Because remember, when you talk about carcinoma of the gallbladder, one of the presentation of carcinoma of the gallbladder is acute cholecystitis. We'll talk about that next lecture when we talk about carcinoma of the gallbladder. So it can also present as acute cholecystitis, gallbladder cancer. The diagnosis of xanthoglomerulus cholecystitis is primarily helped by ultrasound, but the diagnosis finally is made on histopathological examination, and the treatment is usually an open cholecystectomy. Why? It may be so huge that it may not be you will not be able to tackle it by a laparoscopic approach. So you see some of the images of the xanthoglomerulus. Here it is acute cholecystitis. See the huge gallbladder, and here it become fibrotic thickening over a period of time. So you have both the forms of xanthoglomerulus. You have basically the acute form and the chronic form. Then coming to the Mirzi syndrome, which is a very, very important syndrome. So what is Mirzi syndrome all about? So it is named after Pablo Luis Mirzi, Argentinian, and refers to, remember, that's very important. It is not a common bile duct block. It is a common hepatic duct obstruction when it is defined for the first time. But now Mirzi syndrome has become synonymous with block and the CBD also. And what kind of block is it? It is basically a compressive, an extrinsic compression from an impacted stone, the cystic duct or Hartmann's pouch of the gallbladder. But please, for God's sake, remember it is external compression over the common hepatic duct, which is the proper Mirzi syndrome. What we understand as a CVD pressure is not the true Mirzi syndrome. That means the pressure is going to occur proximal to the cystic duct. That means between the cystic duct and the hepatic duct. So the common hepatic duct is the part which is being extrinsically compressed. So 0.1% of all patients with gallstones and 0.7 to 1.8% of all cholecystectomies are Mirzi syndrome. Pathogenesis, number one, there is impaction of stone, a cystic duct, or the gallbladder, or the Hartmann's pouch. This leads to, along with that, there's inflammation. That inflammation leads to coming in close proximity to CHD. There is adhesion with the CHD. Because of pressure of the stone, now ischemic necrosis starts occurring, and that ischemic necrosis then leads to breakdown of number one, the gallbladder wall, and then pressure necrosis continues on that adjacent CHD wall, which undergoes necrosis, and now there is a fistulization between the gallbladder and the CHD. So now the gallbladder is opening into the extrahepatic biliary system by two methods: one, the cystic duct, and number two, through the fistulous communication at the CHD level, right? So it's a fistula into the CHG. That's stage 4 of Mirzi. So now once the stone moves to the CHG, now what's going to happen? Obstructive jaundice. Because initially it was external compression causing jaundice, and now you have got obstructive jaundice because of stone moving into the CBD. 5 to 28% of Mirzi syndrome patients, they show signs of malignancy on histopathology after cholecystectomy, and virtually all diagnoses usually made peroperatively or even more commonly postoperatively with pathological examination of the specimen when we talk about malignancy. But Mirzi syndrome can now be diagnosed primarily even on a CT scan. Now, the classical description of disease includes four components. Number one, a close parallel course of cystic duct and CHD. Number two, impacted stone cystic duct or the neck of the gallbladder. Number three, CHD obstruction, secondary external compression. While cystic duct stone, we already talked about in the pathophysiology and surrounding inflammation. And four, cystodocal fistula. And this completes the fourth stage of Mirzi syndrome, right? If it presents a spectrum, it presents a spectrum disease. That basically means Mirzi's is not one single presentation. It can present as a whole spectrum from mild jaundice to more severe jaundice to acute cholecystitis and of course cholecystobiliary fistula. So the classification is important in the sense that you got two types: the Sendis classification and number two, Mike Sherry classification. But for all practical purposes, Sunday's classification most commonly followed. Type 1, where is only compression. Type 2, fistula involves less than one third of circumference of CHD. Type 3, more than one third to two thirds of the circumference of CHD is fistulized. That means the fistula. So 2, 3, and 4 is basically dependent on the size of the fistula formation. So type 2, the fistula is one third of the circumference of CHD. In type 3, it is more than one third and less than two thirds. Type 4 becomes the destruction of entire wall of the CHD and the stone moving into the extraventricular system. The Mike Sherry classification is simple: fistula, no fistula. Fistula, no fistula. Type 1, no fistula. Type 2, 4 with fistulous communication. Right? And here they are mentioning the percentage, that is one third and one third, two third. It is similar to the Senday's classification. Right? So this shows the Mersey syndrome. And if you just see this figure, it is very, very informative. So the stone is getting impacted out here. See the stone getting impacted out here. Now there's adhesion. So CHD, that's the CHD wall here, and that's the Hartmann's wall here. So getting inflamed and adherent. With adherent, now the wall is breached, there's fistulous communication, and it grows in size, and the stone moves into the CHD. So that is the whole pathophysiological event. Now there is another type 5 where the fistula occurs with the gallbladder fundus with the duodenum. So that is type 5 of Mersey syndrome in certain classification. So that is the fistula which can occur with any other type. So this fistulation can occur with this, or this. So you can have this as a type 5 where the fundus is communicating with the duodenum. So this figure is very informative. I picked this up. So you see the CHD wall, you see the Hartmann wall. See both of them adherent and thickened, and that is the inflammation. And here what has happened? The wall of CHD has broken up, and so this led to the fistulization. And this also causing inflammation of the opposite wall. See, that's why we say more than one third or more than two thirds. That is what is happening. So this is again the representation of the same thing. Now, the symptomatology, acute cholecystitis is there, varying degrees of obstructive jaundice. We already know initial compression, later stone moves into the CBD, and you have much more severe degree of jaundice. Now, there is no consistent unique clinical feature which tells you that this patient got Mersey syndrome. Absolutely not. Clinically, you can never ever diagnose Mersey syndrome. Be absolutely clear about that. Never ever diagnose a Mersey syndrome on a clinical examination. Diagnosis usually an ultrasound, but more commonly a CT scan will make a diagnosis for you. Initially, when we didn't have very good CT scans, the diagnosis was per operative. But now the diagnosis on a CT scan, a CCT can be done, or you can do MRCP or ERCP, or even a percutaneous transhepatic cholangiogram if the bilirubin level is high, and that can define the lesion anatomically. So now you got the whole range of investigations which can define the exact extent of the Mersey syndrome. So is in certain cases, either you can mistake it for a corn bile duct stone if the patient comes to you late and you don't identify the fistulous communication, and that's missed in the preoperative workup. So when you're operating on this patient, either laparoscopically or ERCP, and you find that there is a second communication, so that may be missed, but more often than not with the MRCP, ERCP, or a CT scan, usually you know, right? In early days, I told you it was usually a peroperative diagnosis. So the treatment is simple. Stage 1, do a cholecystectomy. Simple cholecystectomy. You may require a CBD stenting or T-tube insertion, may be necessary in stage 1, but usually not required. But if you manage to damage the CHD, then of course you have to go in for stenting of the CBD, either endostenting or external stenting with the help of T-tube insertion. But if you have stage 2 to 4, which are some degree of adhesion with fistulization, then a partial cholecystectomy is the best option if you have gone in laparoscopically and you made a diagnosis on the table. Then do a partial cholecystectomy with stump closure, which we talked about in the earlier slide. Or you can do a complete cystectomy with a CBD repair over a stent, or bilioenteric anastomosis, Roux-en-Y hepatogenostomy, or all these have shown good outcome in some studies, but this would be there if the patient has come to you in delayed Mersey syndrome. Remember, in acute Mersey syndrome, none of these would be tenable. None of these are tenable. These are all for those patients whom you have diagnosed Mersey syndrome and you don't operate at that point of time. You wait for the things to quiescent down, and once they are quietened down, only then you go ahead and do a bypass operation in these patients. The Bovard syndrome is another type of acute cholecystitis. Here, this is a large stone migrating after pressure necrosis, so cholecystodunal, cholecystogastric fistula, gastro obstruction, or the gallstone ileus. So the name of gallstone ileus, if you look at the name, it is the Bovard syndrome. So gallstone ileus and Bovard syndrome are synonymous. Another name for gallstone ileus. Seen in about 0.5% patients with gallstone disease. Out of these, Bovard syndrome is seen in 1 to 3% of patients with gallstone disease. Right? Treatment: cholecystectomy, take down the fistula, and repair of the enteric defect. Now, a question on prophylactic cholecystectomy. Should you do a prophylactic cholecystectomy? Yes or no? In a gallstone disease, it is advisable. The patients come to you with symptoms. Yes, go ahead and do it. But more often than not, there are patients who come to you with a gallbladder, with a ultrasound in hand, and look, I've got a stone, and you ask, you take a history. You say, I never had any kind of pain. I never had any kind of dyspepsia. Nothing, absolutely nothing. Now the question arises. He asks you that whether I should go in for a cholecystectomy or not, and that is a burning question, right? Now, there are both opponents and proponents. Now, opponents who say prophylactic cholecystectomy should not be done, what are the points that they put in favor? Number one, they say 1 to 2% chance of gallbladder CBD injury, increased incidence of post cholecystectomy syndrome, 1.5 to 1 ratio of colonic cancer. That means post cholecystectomy, colonic cancer is now a known entity. That means after your cholecystectomy, it alters the biliary salt metabolism in such a way that there is an increased incidence of colonic. Duodenogastric reflux comes into play, and diarrhea, post cholecystectomy diarrhea. So these are the reasons put forward by opponents of prophylactic cholecystectomy. But what are the proponents? What are the reasons why they say you should do it? Number one, possibility of acute cholecystitis plus complication. Incidence of gallbladder cancer 0.5% in the West. But remember, the actual figures of India are much, much higher. We don't have exact figures, but the incidence of carcinoma gallbladder post stone identification is very high. Why? Because the incidence of gallbladder stone disease is very high in India, especially in the Kashmir area and the Gangetic Belt. Western recommendation based on 7 to 25 years study, but Indian population involvement of 20, 30 years have a much longer lifespan of 50, 70 years, and this chance of carcinoma gallbladder is higher. The reason is that you diagnose stone in the Western world pretty late, so there the lifespan for which the person is having the stone is shorter as compared to the lifespan for which the patient in the Indian subpopulation is having the stone. It's almost 50 to 70 years he's having the stone inside. So the chances, obviously, of having carcinoma gallbladder increases in the Asian population, especially in the Indian population. So when is it indicated prophylactic cholecystectomy? Number one, geographical call. Kashmir and Gangetic Belt, go ahead and do a prophylactic cholecystectomy. If the patient has comorbid conditions along with asymptomatic gallbladder stone, like diabetes, congenital hemolytic anemia, bariatric surgery, doing bariatric surgery, go ahead and do a prophylactic cholecystectomy. Or certain patient factor, like for example, a young patient, say a patient who's been diagnosed with gallbladder stone at the age of 6 years or 10 years. We have patient, we operated day before yesterday on a patient of 6 years with gallbladder stone. So that patient is going to have stone for the next 50 years, 60 years, 70 years. We don't remember it. So if you've got a life expectancy of more than 20 years with a stone, go ahead and do it. Multiparous and first child before 25 years. Some gallbladder factors are also important, which indicate that a prophylactic cholecystectomy should be done. Number one, thick gallbladder wall, more than 3 millimeters. These are xanthogranulomatosis. Stone size more than 3 centimeters size. 10 times higher risk of carcinoma gallbladder. High stone gallbladder volume ratio. That basically means that patient's got, let's say, 100 stones, 150 stones in a small gallbladder. Large sessile polyp, more than 1 centimeter size. Incidence of carcinoma gallbladder 10%. So you have to go in and do a prophylactic cholecystectomy. Anomalous pancreaticobiliary ductal urine. Porcelain gallbladder, always do a cholecystectomy. Why? 5 to 10% chance of carcinoma gallbladder. Brazil syndrome, because the patient got fistula, do a prophylactic cholecystectomy. Biliary reflux after bilioenteric bypass, do a prophylactic cholecystectomy. And chronically obliterated cystinoid, do a prophylactic cholecystectomy. Right? What about chronic calcareous cholecystitis? Chronic calcareous cholecystitis basically a variant where you got recurrent pain with low grade inflammation and two-thirds of the patients with gallbladder stones. That means chronic cholecystitis, if you look at the analysis, you'll find two-thirds of these patients will be having a coexisting gallbladder stone. It doesn't mean two-thirds of gallbladder stones have chronic cholecystitis. Please don't go with that information in your mind. If you look at 100 patients with chronic cholecystitis, then two-thirds, that means 70, about roughly 70% of them would be having a Schilling gallbladder stone. Scarring and non-functioning gallbladder is a rule. That's why I call it a chronic calculus cholecystitis. Histopathologically, subepithelial, that means beneath the mucosa of the gallbladder and the serous of gallbladder, you will find fibrous and mononuclear cell infiltrates. The symptoms in the form of recurrent biliary colic, nausea, vomiting, bloating, belching, 50% intolerance to fatty meals. Number one, typical biliary pain, intermittent, and dyspeptic symptoms. The patient may not be having pain. The second option, patient may be having dyspeptic symptoms. The diagnosis, ultrasound, and how would an ultrasound help you? It will show number one, wall thick. It will show you reduced size of the gallbladder. It will show you non-function, that means less than 50% contraction after fatty meal. In a chronic alcohol cholecystitis, feed him a normal meal, do a pre-meal gallbladder, and within half an hour do a further ultrasound scan. You should have a 50% reduction in size of gallbladder. If it is less, the patient is chronic cholecystitis. Treatment is of course cholecystectomy. Then cholecystosis, that's the last condition we'll talk about today. Next time we'll talk about the complications. So this cholecystosis is nothing but chronic inflammatory condition with hyperplasia of all tissue elements. Manifests as either number one cholestrosis or manifests as cystitis glandularis proliferans, or manifests as cholesterol polyposis, or it can manifest as diverticulosis. So four types of cholecystosis manifestation. So first is the strawberry gallbladder, where you find the typical speckles of yellowish mucosa, yellowish speckles on the mucosa, just like gold seeds. They correspond to seeds, and may be shared with or without stones. These are just nothing but cholesterol crystals in the lamina propria and cholesterol esters. The glandularis proliferans basically means all layers have been proliferating, so they can present as small polyp, present adenomyomatosis, intramural diverticulosis, stones, and fistula formation. The polyposis is important if the size is more than 1 centimeter. Always less than 6 millimeter periodic follow-up is required. 6 millimeter to 1 centimeter is the gray zone. It is always better to operate on these patients. And if you have got diverticulosis with black pigment stones, that is the time when you should operate on these patients. I think we'll finish here. We're just mentioning the complications of laparoscopic cholecystectomy, and the standard of care we'll talk about next time. So you're doing a cholecystectomy, you're looking at possibility of a CBD injury, collection in the Morrison's pouch of bile or blood. You're looking at hemorrhage. You're looking at post-operative jaundice. You're looking at biliary peritonitis. You're looking at bowel injury. I think that should be uh, enough for today, and we'll be talking about the post-cholecystectomy syndromes next time. If you have any questions, you can always get back to me, and we'll talk about that later. Thank you for your time.